Well, hi, good evening, folks. If somebody could just drop in the chat whether or not you can hear me okay. Wonderful. Thanks, Jamie. That's perfect. So, are a couple just joining by the looks of things. I'll blame the nice weather we've been having and the fact that this is the first webinar we've done in a very long time. I was looking back over the last few weeks and December 2021, would you believe, was the last time we sat down like this. And it's certainly some memories of COVID coming back, lockdown times while I was doing this. So great to see familiar faces. I think I've seen everybody that's here. I think we've seen before, haven't we? So that's fantastic. It's really nice. Thanks for coming back. And obviously, this is first in another series of free webinars. We're going. Let's just let Paul in there. So we're going 2 weekly at the moment, just to start with, because it is quite a lot of work. I seem to remember taking up quite a lot of the time back in the day, and no different at the moment. So we're going to start this new series, which is pre-hospital care series. And anything is on the cards. So if you have any suggestions for things that you'd like to be covered, please do let me know at some point. And I've got a few things in mind that I'll start off with. There's no real order to what I'm doing. It's just these have all been subjects that in recent practice have caused question or confusion and stuff that we've been discussing on jobs, and I thought actually were worthy of discussion. And that first topic was fluid guidelines, boring as it may seem, actually quite a complicated area, and I think an area that perhaps we can do slightly better in, or certainly change our practice in some areas. So thanks, Brian. It's nice to see you again. So. We will make a start. Thanks for those of you that just held on there for a few minutes. As I say, we are expecting somewhere in the region of 30 to 40 people tonight, but I'm going to blame the good weather for the fact that they've all gone off to the pub instead. So let's get PowerPoint up and running. So you've all met me before, but listen, do pass the word around, and obviously this goes out on YouTube for anyone to watch. I'm out there. I'm freelance. I'm available if you need a paramedic for your event, and then please do get in touch. Over the last few years, a lot has happened actually. So we've had goodness, we've got married, we've had a child that's now running around, and we've moved house, and we're both in different jobs. It's all just pretty much everything has changed. STC still exists, still do private bookings and things like that, but we've moved away from delivering FREC courses. It's just the workload versus what we get out of it just wasn't worth it. And I think Qualsafe have dealt themselves a bit of a blow recently with putting quite a significant annual fee on centres. So actually, as a small centre, it doesn't make sense to continue delivering FREC courses. So STC will probably just carry on doing the little bits and pieces that I still do in terms of BLS for healthcare professionals. I am shortly to become a Resus Council ALS instructor, so whether that will fit into our future goals, I don't know yet. But so still around, we're still an entity, but my time is now being spent very much on delivering freelance paramedic services across the UK. So do get in touch, anyone that's watching this that's of interest. I have to get the plug out. I'm not charging anything for this webinar, so. As I say, been a very long time since we've sat down and done this. So we are going to start this series with fluid guidelines. I've got some subjects that I've done some kind of work towards already for doing presentations on. These are what I've kind of come up with so far that what we're going to be doing webinars on over the coming months. Pre-hospital bloods is an area I'd like to talk about. We're going to look at the other drugs, I've termed them, in advanced life support. So what they are, when we might use them, and how they work. Going to have a little look at magnesium. Magnesium is becoming very popular now in pre-hospital care. So having a little look at how that works and the times that might be beneficial to our patients. Life-threatening arrhythmias, say bradycardias and tachycardias, looking at how we manage those in adults and children. Diazepam versus midazolam. Midazolam is certainly taking off now as the replacement for diazepam. Those of you that work pre-hospital know diazomols, the old version of diazepam that we all used to use, has been discontinued. Lots of trusts are still using diazepam on PGD, but actually there's so much evidence out there that midazolam is the drug we should all be using, and many of those trusts are now changing. So just having a little look at the differences between those. and also having a look at this flumazenil, which is the one of the drugs that they're proposing becomes licensed for paramedics under Schedule 17 Part 3, so may not require a PGD. That's obviously a benzodiazepine antagonist, so for benzo overdose. And as I said, I'm really open to suggestions. So if there's a particular subject you want me to talk about, please do let me know, and I will certainly have a little look into it. And if there's appetite for stuff, it'll become an episode. So, without further ado, then let's get into tonight's session. We can have a little look at current pre-hospital guidance around fluid administration. We're going to have a look at some of the limitations around fluid administration, particularly in the context of resuscitation. There are lots of different areas of a patient's journey that they may receive fluids, particularly in hospital. But now out of hospital, predominantly we're giving fluids for the purpose of resuscitation. So we're looking at limitations of that. We're going to talk about sodium chloride versus Hartmann's. Those of you that never come across Hartmann's, its true name is sodium lactate compound, often known as Hartmann's or Ringer's lactate over in the US. Having a look at the differences between the two, why we might choose one over the other if you have them both available to you. Have a look at the role of hypertonic saline, which is definitely a developing area of practice in traumatic brain injury patients. We'll have a look at cold versus warm with regards to fluids. Should we be warming our fluids before we give them? We'll have to talk about glucose. It is a fluid. It's not used for resuscitation, but we'll talk about that. And then, of course, there'll be the Q&A session at the end. Appreciate that the vast majority of people watching this webinar are going to be watching it back on YouTube. So again, if you have any questions, comments, feedback, anything like that, just drop us an email. Email address and telephone number that you can WhatsApp us on are at the bottom of the screen on all of the slides. We want this to be interactive. I appreciate it's a small audience this evening, so even more so. Let's get those questions in the chat. I've got the chat open, and you can always message me and email me if you don't want anyone to see your comments or feedback. That's absolutely fine. And we're going to be using Mentimeter again, like the good old days. So get your smartphone ready or whatever device you want to access it on. There'll be a few quizzes as we go along tonight. It's menti.com, and the code will come up on the screen when we get to the relevant points. So we're going to start with a case study. So you've got a 24-year-old female camera operator. You're on a film set, and unfortunately, we've frozen. The camera tower has collapsed onto her. It's an unfortunate incident. So you've got a significant head injury. That's the most from your quick trauma top to toe and primary survey. You're most concerned about a significant head injury. That's our starting point. There's some observations for you. Respirator 16, quite normal. SATs of 96% on room air. I would imagine you're going to want to be putting this patient on oxygen regardless because of the head injury. Significant trauma. Heart rate is 62 and regular. Blood pressure at the moment is 99/50, and she does have a significantly reduced GCS with a scale of 1, 2, and 3. So, eyes 1, if you remember, is no response. Voice 2 is incomprehensible sounds, and motor 3 is withdrawing from pain. Sorry, it's not. It's decortical posturing, not withdrawing from pain. Decortical posturing. So, total of 6. That's quite a significantly reduced GCS, and obviously is going to be quite concerning. The airway is being managed, the respirator is being monitored, and you or your colleague has gained IV access. You're told that there's no significant past medical history, but that's all you know about this 24-year-old female. The question I'm posing to you before we start tonight's session, based on JR Count guidelines, is this patient indicated for intravenous fluids at this stage? So there are the observations. We've got a significant head injury, blood pressure 99/50. Are we going to go and give this patient some IV fluids straight off the bat? So now is the time to go to Mentimeter. Head to menti.com. I'm not as slick as I used to be with all of this technology. I seem to remember it was, there we go. Hopefully you can all see the Menti screen now. And it should say part 1 of 3 is the patient indicator for fluids. The observations are still there on the screen. If you grab your smartphones and go to menti.com, put the code in at the top. Somebody has just joined, so I'll give them a few minutes. So head to menti.com, put the code in 41288442. You should see this come up on your device, whatever device you're using. It should present you with this question. It's a yes or no answer. Is this patient, your 24-year-old female that's had a significant head injury, that's all you've found at the moment, are they indicated for IV fluids? Respirator of 16, SATs of 96%, heart rate of 62, blood pressure 99/50, GCS of total of 6 with a scale of 1, 2, and 3, eyes 1, voice 2, motor 3, significantly reduced GCS. You are concerned about this head injury. Don't let other people's answers sway you. So far, 60% of you going no, 40% of you going yes. I didn't catch the name of whoever just joined, but I'll give you a few minutes just to log on. This is you've not missed anything, just the introduction. We've got a case study, 24-year-old female, was a camera operator on a film set. The camera tower has collapsed on her. She has a significant head injury. Those are her observations. And the question I'm posing to you at the moment, as per JR Calc, is she indicated for IV fluids? Oh, there we go. I can hide the responses so you're not swayed by other people. There we go. So there's 6 people logged into Mentimeter, only 5 so I'll just give whoever that last one is a minute just to decide. I'm not as slick with Mentimeter and things like that, you see. Can't remember all these little tricks to make everything run smoothly. Maybe it's good there's only a small audience tonight. So there's 5 of you logged into Mentimeter, only 6 of you have voted so far. So is this patient indicated for IV fluids based on those observations and that very short basic history of a significant head injury? I'm going to go ahead. So 60% of you have gone for no, 40% of you have gone for yes. The 40% of you are correct. In the context of an isolated head injury, we are looking to maintain a blood pressure in excess of 110 millimeters of mercury. So the blood pressure of 99/50. In the context of an isolated significant head injury, we are indicated for fluids. We will come back to this in more detail. There are a couple more questions based on this. So just giving you the answer to this one. So we'll skip that one and we'll go on to part 3. You discover significant blunt abdominal trauma as part of your secondary survey. This same patient, you significant blunt abdominal trauma. What does that change, if at all, your target systolic blood pressure to? So this is the same 24-year-old female that's had a significant head injury. Once you've managed her and you've started some fluids running and you do a secondary survey, you find significant blunt abdominal trauma. Does that change your target? And if so, to what? So whenever you're ready, please answer that. So 90, 100, 110, 120, 140. What's the target? As I always say with these quizzes, you learn more by getting it wrong. So if you don't know, have a guess. Try not to look it up before you vote. Generally, you always learn. You do learn more if you have to guess a little bit. So 3 of you have voted. 3 of you haven't. You don't have to if you don't want to, but I will start to show you where people are going. So I gave you the answer to part 2 by mistake. That was 110. Does that change now that you've discovered some significant blunt abdominal trauma? In the interest of time, I'm going to show the answers. Okay, a range. So everybody's saying it's changed. So 1 of you has said it increases to 120. 2 of you have said it decreases to 100, and 1 of you has decreased to 90. And the 1 of you that has decreased to 90 is correct. This is where intravascular fluid guidelines in trauma get quite complicated. And the whole point of tonight's session is to go through these. So I'm glad that it's highlighted what I've seen out in practice, which is people getting confused by what targets we should be going for. So thank you for that. I'm sorry it wasn't quite as smooth as normal. I gave you the answer to the middle one, but these are the current guidelines. So there are 2 sets of guidelines broadly out there that manage fluid guidelines. In hospital, it's NICE. They're on in hospital colleagues tend to follow NICE guidelines. We in the pre-hospital arena are much more familiar with JL Calc. Now, JL Calc is based on NICE. They don't disagree at any point. I always do it whenever I have to go and compare NICE guidelines with JL Calc guidelines. I always come away feeling that NICE is very holistic in its approach. It relies on you as a clinician forming your own judgment over what's best for that patient using lots and lots of available information. And here's some things you might want to consider in making that decision. That's generally how NICE works. JL Calc says you need ABC to do D. That's so they're very prescriptive in their guidelines. Now, some people do better with that. I tend to favour that much more. This is what you should think about, and these are the options available to you. I prefer that as a clinician, but I'll be completely honest with you. At 2 o'clock in the morning, when I'm caffeine starved, I'd much rather somebody just tell me A, B, C, and D. I'm happy with that. So there are places in my heart for both of them. JLCAT guidelines, whilst they are prescriptive, they are still complicated. So broadly speaking, we split our patients. We're going to focus on JLCAT for the rest of the evening. We're not looking at nice guidelines for things now. This is a pre-hospital care series. So we're broadly speaking, we need to distinguish whether our patient is hemorrhagic or non-hemorrhagic. So basically medical versus trauma, but not quite that simple. JLCalc tell us that in order to decide whether somebody needs fluids, we need an accurate systolic blood pressure, ideally, and we need to make a clinical assessment of their perfusion status. So that means looking at those other signs. Blood pressure isn't the be all and end all. Some people have a normal blood pressure of 90 systolic. So to say that they need fluids at 89 is nonsense. So you need to take that bigger picture in, as you do with all patients. But they do highlight that fact. So looking at things like capillary refill time in a patient in a warm environment is a useful marker. Looking at those signs of hypoxic agitation, looking for the increased heart rate and the respiratory rate, those early signs of circulatory compromise. I'm going to come back to accurate systolic blood pressure. Those of you that have had any experience with critical care and invasive blood pressures know that non-invasive blood pressure, the blood pressure cuff on the arm, isn't that reliable in patients that are critically unwell. It tends to overestimate. So your brachial artery blood pressure that 99 out of 100 patients would get on the roadside will tend to overestimate in patients that are profoundly hypotensive, and that's not useful, clearly. And conversely, it does the opposite in the other way. It tends to underestimate severe hypertension. Again, not useful. So, but invasive blood pressure isn't routinely available pre-hospitally, so we have to make do, and that's why it is important to bring in those clinical assessments of perfusion. Just because the life pack's telling you their blood pressure is 100 might not actually be. So if they're showing all the other signs of shock, you may still want to go ahead. They do also mention where you can't get accurate blood pressures, you can use clinical judgment over the presence or absence of peripheral versus central pulses to estimate. If you remember, I think I've talked about in previous series that if you've got a good strong radial pulse, you've probably got a blood pressure over 90 millimeters of mercury. If you've got a palpable carotid pulse, you've probably got over 60. Um, so the other things that are mentioned, but but that's it really, is this thing of mean arterial pressure, and I think that comes in useful when we start to talk about this next question. So what about patients that are hypertensive? And mean arterial pressure is really the sum that tells you whether this patient is going to be getting end organ perfusion. And depending on the literature you read, anything between 70 and 100, 70 and 110 is considered normal. Anything less than 60 is considered significantly low, and perhaps there's going to be poor perfusion to the core organs, those life-preserving organs. How do we calculate it? It's not something you can necessarily just do off the top of your head. But you can get a rough idea once you've done it a few times. So it's your diastolic plus 1/3 of your pulse pressure. Your pulse pressure is your systolic minus your diastolic. So it looks complicated. But let's take your patient with a blood pressure of 120 over 80, for example. You're going to add 80 to 1/3 of the difference between 80 and 120. So 1/3 of the difference between 80 and 120 is what, just less than 20. So you're going to be in the 95, 96 region. That's how we calculate mean arterial pressure. Anything over 70 is considered normal. Anything over 110 suggests significantly raised blood pressure, which will become more important when we talk about head injuries later. Anything less than 60, we really should be thinking about fluids and things like that in those patients. And this applies to patients in hypertension as well. You've got a particularly keen eye on those ones that are normally running at about 150 over 100, not that uncommon in the population out there. Some may know it, some may not. When they start to lose their diastolic, that's when you start to see a massive drop in mean arterial pressures. So those patients that normally run at 150 over 100, they drop their diastolic because they're starting to decompensate, and suddenly their mean arterial pressure drops off below 60, and they're losing consciousness. You see it in the elderly quite common, those vasovagal episodes, and where just even just for a temporary non malignant reason they've dropped their blood pressure. That's why they're so susceptible to it. General guidelines when we're giving fluids: don't just whack your fluids in. If you do decide to give them, always just flush first, because you don't want to tissue large volumes of fluids. And they've gone away from this old school method of slow administration. It used to always be known as KVO or TKVO, to keep the vein open. So slow administration to maintain patency of a line. It's considered outdated and poor practice nowadays. The main reason is because you don't actually know how much fluid you're giving to a patient. You've got a bag of fluid connected to a line dripping away, and actually, who knows how much fluid that patient's going to get. I mean, we generally deal in 500 ml bags, so they're not going to get liters, but it's considered poor practice. Certainly something I've done in the past, and certainly something I'm not going to promise not to do in the future. But it's just so you're aware that keeping vein open with slow infusion of fluids is no longer considered good practice. So when we're dealing with our hemorrhagic emergencies, these are probably the ones we probably jump to the most with thinking about patients that need fluid. We've got to consider apparent and concealed hemorrhage, so your external versus internal. Clearly, where possible, controlling the hemorrhage first. We've all heard the stories about Dear Liza's Friends bucket. There's absolutely no point putting fluid into a vessel that's leaking. Ultimately, control the hemorrhage first, but clearly, with concealed hemorrhage, you are going to be limited to what you can do in terms of compressible hemorrhage control. We're going to be looking at things like your pelvic and traction splinting. We're going to be looking at other agents like TXA. Our main trigger to give fluid in both hemorrhagic and non-hemorrhagic is impaired organ perfusion. It's talking about this clinical shock, isn't it? And that's where your clinical assessment comes in. It's not just blood pressure, although the blood pressures are suggested as limits. You are looking for those various things. We're going to further categorize our patients into our trauma, or our hemorrhagic emergency is going to be further categorized into one of four. So if you think your patient is hypovolemic because of blood loss, you're going to decide, is that blood loss as a result of penetrating trauma to the trunk, penetrating trauma to the limbs, blunt trauma to either the trunk or limbs, or some form of trauma to the head. We're going to categorize them in one. Clearly, some patients are going to cross boundaries here, aren't they? So if they fit into more than one category, treat for what you think is the one most likely causing the shock. That becomes important because some of these have different targets of treatment. And we've just come across it in the introductory case study. Patients with trauma to the head, we maintain a higher blood pressure than patients with trauma to the trunk. Okay. As with all treatments like this, the evidence base around fluid replacement is slim at best in the pre-hospital environment. We shouldn't be delaying on scene. It's the same as any other intervention we do. These patients, if they are bleeding out and we can't stop that, and even if we can stop it by means of a tourniquet, they need to be in front of a vascular surgeon. They don't need to be at the side of the A40 receiving an extra bolus of fluid. So. Oh, what's it not doing anything? There we go. So let's have a look at these areas in more detail then. So we'll start with possibly the hardest group of patients to manage, and that's the penetrating trauma to the trunk. You've had a stab wound somewhere centrally, thorax or abdomen, and that's perhaps ruptured a vessel, and you're bleeding internally. They're large cavities. They can absorb, or not absorb, but they can conceal significant quantities of blood volume. So the issue here, of course, the clear limitation here is we can't compress that hemorrhage. We can't stop that bleeding without being joined by our orange sky gods. We can't do these things that with the thoracotomies and the reboas, the balloon occlusions, the aorta. There's only a couple of things really that can be done for these patients. So these are, as I say, the hardest to manage as a core kind of ambulance response to these types of patients. So and coincidentally, they have the lowest target blood pressure. Does anyone want to throw in the chat why that might be? Why are we not looking to so if you see on there, so the target of systolic blood pressure for these patients is 60 millimeters of mercury. As you'll see as we go through the guidelines, most of the time we look at about 90 being the cutoff for your healthy adults. We start fluids once they drop below 90 for whatever reason is going on. In penetrating trauma to the trunk, we delay that. It's a term you'll hear is permissive hypotension. We allow them to drop their blood pressures to 60 before we start intravascular fluid. Does anyone want to chuck in the chat why that might be? Why do you think somebody with a significant blood loss from one of the major vessels in the thorax or the abdomen, why you wouldn't want to start pressing them and getting their blood pressures back up? Yes, absolutely. To keep off any clot that's been formed, fantastic. But do you think so? So if somebody's nicked their aorta, is that likely to clot? And actually, is increasing the pressure going to just make it leak more? They're the types of things we're thinking about. That's what the evidence suggests behind these patients. So actually filling them up with fluid and trying to press them and increase their cardiac output and increase their systolic pressures in the aorta. If the aorta is leaking, you're just going to leak more. You're just going to make the puddle inside them bigger. So that is the thinking. And actually 60 coincides roughly, TXA, good, I like it. So 60 coincides roughly with the minimum pressure required to get some blood up to your brain. So at that point, we are just preserving brain and those kind of central kidneys, liver, perhaps be getting enough perfusion that they're not going to stop. And of course, crucially, the heart, the coronary circulation is going to be preserved. So when those patients are bleeding and you're watching their blood pressure drop on the monitor, we're not actually going to start fluid until we get to about that 60 mark. But they do say we need a palpable central pulse. If you can't feel a pulse in the neck, they're probably not getting blood to their brain. And if they're deeply unconscious, they're probably not getting blood to the brain. So you've got to use these things in. We want to try and maintain palpable central pulses, and we want to maintain some level of cerebral perfusion, which is going to manifest as the patient being at least awake, maybe not fully alert. Penetrating trauma to the limbs and blunt trauma to the trunk and limbs it just conforms to standard guidelines, which is we want a peripheral pulse, so we want to feel a radial pulse, and ideally we want to see a blood pressure of around 90. The caveat here of what do you do with hypertensive patients still comes in. Your hypertensive patients that normally run about 150 systolic are definitely going to be symptomatic at 90. We want to be having a bit of clinical common sense applied in those situations and decide would they benefit from fluids. We'll come on to a little bit about what the fluids do and what are we trying to achieve a little bit later. And then trauma to the head, the one that we've talked about in that opening case study. So where you have a head injury that is exclusively causing hypotension through blood loss. Now, reread that a couple of times and just appreciate that that is a really rare scenario. Head injuries, just because of the very nature of closed box and actually the blood vessels that supply them being relatively small, neck exceptioned on that, the likelihood of having a bleed intra or extracranially that's going to be significant enough to put you in hypovolemic shock is quite rare. That being said, patients that drop their blood pressure in the context of head injuries don't do very well. We will go into head injuries in a lot more detail, but ultimately we're trying to perfuse these patients well enough to overcome their increasing intracranial pressure. If their circulating blood pressure isn't high to begin with, they are never going to be able to ramp up their mean arterial pressure enough to overcome that intracranial pressure to preserve cerebral perfusion. That's just not going to happen, but we will look at that in a little bit more detail. I've put but treat for the most likely cause. Again, it goes back to that previous slide of if your patient sits in more than one category, they've got a significant blunt trauma to the head, but they've also been stabbed in the chest, and on their monitor, their peri-arrest, in a really obtunded state, really low blood pressures. What is more likely to be causing that hypovolemic shock? Is it the head injury or is it the penetrating trauma to the trunk? What the guidelines say is we should treat that patient in line with that. So we should permit their hypotension to 60 and then we should start treating that with fluid therapy. The reason I put the question mark there is it does pose this big question. I can guarantee you now, if somebody has a significant head injury and they've got raised intracranial pressure, even by the slightest margin, if you're allowing their systolic blood pressure to drop to 60, there is no way in hell that their mean arterial pressure is going to be significant enough to it's high enough to overcome that intracranial pressure rise. They are not going to have cerebral perfusion. You are pretty much guaranteeing them secondary brain injury by not bringing their blood pressure up, but you're balancing that against what we just talked about. If you then do think, oh, do you know what? Actually, I'm going to perfuse the brain over everything else. Let's give them fluid and get their blood pressure back up over 110 systolic. You've now increased the pressure on that clot that maybe have developed, or that small leak in the aorta that suddenly turns into a significant bleed. And actually, as fast as you put the fluid in, it comes out anyway. These are really difficult patients. There is no correct answer in that situation. That patient is probably going to die either way, realistically. But these are where the guidelines sometimes come together, and they do make you think as a clinician, well, hang on a minute, what's the target here? And actually, if both outcomes are poor, which one do we go for? Um, so the once you've decided to give someone fluids, the guidelines around when to give, I think, are difficult. But actually, broadly speaking, in adults, we give all fluids now in 250 ml boluses. There are some exceptions, but broadly speaking, 90 millimeters of mercury and 250 ml boluses. We give them as required. You are expected to assess in between each bolus to decide whether the next bolus is still clinically indicated. We're not supposed to do what we used to do of just saying, well, they're good for up to 2 liters. Let's just run bag after bag after bag on the way to hospital, and we'll stop when we hand over. That used to be done. It probably still is done, but we are expected to reassess after every 250 mil. For the vast majority of places I've worked, we use 500 mil bags. That's every half a bag. We should stop, reassess. Do we need to continue, or can we pause there? We'll come into some of the limitations because most of the time we're using normal saline, and that does have downsides in large quantities. As I say, we'll flip back to the last page with the caveats that it's not always 90. In trauma, penetrating trauma, the trunk, permissive hypertension down to 60, head injuries 110. Once you decide to give it, the treatment is the same, 250 every it ends up being probably 5 to 10 minutes, and then reassess in between each one. The one thing, the one little caveat on its own, that spans a little bit between trauma and medical causes is these crush injuries. So there's this thing called crush syndrome. Its proper name is traumatic rhabdomyolysis, which of course any of you that have dealt with elderly fallers will be familiar with rhabdo and the need to get bloods once they've been on the floor for more than 2 or 4 hours, depending on your local guidelines. It's the same principle in effect that myoglobin is released from the skeletal muscle and it's compressed and dies. It dies of local ischemia because where it's being compressed, it's not getting perfused. So and when it's reperfused, you get reperfusion injury, you get release of myoglobin. That myoglobin is metabolized into many different things that aren't necessarily poisonous to the body in normal quantities, but they're usually released in quite significant quantities. They can cause huge problems with the kidneys. That's usually the number one thing in your elderly fallers. They get horrendous AKIs, acute kidney injuries from all these toxins that are released. But actually, in traumatic rhabdomyolysis, where you've got significant crush injuries, I always think of I think the worst one I can recall dealing with was somebody that had been hit by a car and pinned between the car and a building. There was more than just traumatic crush injury going on here. There was obviously pelvic fractures and bleeding on top of everything else. But the what you get in those large quantities of a large area of muscle being destroyed, you get huge releases of things like potassium, and becoming hyperkalemic that quickly, your heart absolutely hates and goes into life-threatening arrhythmias and circulatory collapse very, very quickly. The guidelines always talk about these patients that are absolutely fine. You remove them from their car and they die. That's not how that picture unfolds. Those patients are not well, but you see a notable collapse after rescue. If you're seeing that picture developing in front of you, you've got someone you're worried about Clearly, they've been in a horrible car accident. You're worried. You know, but once you release them, you see that significant decline in their presentation. If there was any risk that they have been crushed, we're not talking small amounts like a wrist or something like that. We're talking chest being crushed, assuming they can still breathe, of course. We're talking entire limbs being crushed. You think about those high impact head-on collisions where you've had movement of the dashboard and those types of things, and those patients are trapped. Think about crush syndrome being a possibility. We are proactive rather than reactive with our treatment of crush injuries, and the aim is to dilute those toxins to reduce the effect. So ideally, what we want is to dilute the blood before those toxins are released. It's not always possible, in fact, very rarely possible. So just treat as soon as possible after your risk is identified. And the treatment for this is really aggressive. It's 2 litres stat dose of whatever fluid you have available, normally normal saline, rapidly infused. So literally, the patient I dealt with was 2 large cannulas and a bag of fluid on each side being squeezed, and then replaced with another bag. So as I say, that's 4 bags of fluid going in as quickly as you can. So quite significant. And that's really different from how we manage fluids in any other situation. I think the evidence is quite weak on whether that makes a huge difference. Large amounts of sodium chloride entering the body that quickly aren't good either. But I suppose it's on the benefit of it. It has a theoretical benefit, but I couldn't see any good strong evidence around its use. But they are the guidelines nonetheless, which brings us to the end of the hemorrhagic emergencies. And I have got another little quiz for you. So we'll go back to menti.com. Hopefully you can all see that. It's the same code if you haven't logged out. I see 7 of you logged in now. That's good. Somebody else has joined us. So your patient has a blood pressure of 117/92. I'd like you to try and calculate their approximate mean arterial pressure. So blood pressure 117/92, what is the map roughly? It does come out as a decimal point, so just go for the closest answer. And that formula I gave you is only an approximation. The formula that these online calculators like MD Calc and all that use is more involved, but of course we are not calculators. So, and at 2 o'clock in the morning, you're very lucky if I can calculate an MAP. I'm relying on the life pack to do it for me most of the time. So I'll give you a few minutes. Only one of you's voted so far, so it's always more fun if more people do it. So if you're not already on the everyone is apparently showing is logged into Mentimeter. So the 6 of you, 5 of you now that haven't voted, do please vote. Have a little go, see if you can figure it out. If you can remember that far back. If you can have a go. I'm just conscious of time. I don't want to stay on the slides for too long because we will run over quite considerably otherwise. Let's see what people are going. 50/50 over 117 over 100. I made it 100. So 92 plus 1/3 of the difference. So 117 take 92, do 1/3 of that. It came out at about 8, just over 8. So 92 plus 8 is about 100. So, which is normal, isn't it? 117 over 92 we know is normal blood pressure and mean arterial pressure. Well, the diastolic's a bit high, but the mean arterial pressure there of 100 is in the top end of normal. So depending on which guideline you look at, 70 to 100 is considered normal. So that's a slightly elevated blood pressure overall, or mean arterial pressure, but that's because of the diastolic being higher. Hopefully that makes sense. So we've got another question coming up. Your patient has been hit with a baseball bat in the ribs and has been stabbed in the thigh. So somebody really didn't like this chap or chapette. So baseball bat to the ribs and a stab wound in the thigh. Oh, and it is a chap. Blood pressure is 85/40. Select the correct therapy. Not indicated. 250 ml normal saline reassess. 1 litre over an hour or 2 litres rapid infusion. What are you doing for this patient? We've got a baseball bat to the ribs and a stab wound to the thigh. Blood pressure is 85/40. What are you doing? No fluids, 250 and reassess, 1 litre over an hour, 2 litres rapid. All vote now. Just a couple of you voting. Good, perfect. So with a small audience, it is nice if you can just have a little go on these things. If you're having major issues with it, do Do you see any massive external hemorrhage? No, you can assume there is some external hemorrhage, but no, we're not worrying about somebody else has done the tourniquet or whatever other treatment is needed. You're just there to give fluids. Are you going to give this patient any fluids? If so, what dose are you going to give? Let's see what we're all voting for. Everyone's going for that one, which is good because that's the correct one. So well done. Yes, absolutely. It was a question just designed to make sure you'd picked up on that. Had that been stabbed in the ribs and a baseball bat to the thigh, of course, we would be waiting for 60 millimeters of mercury before we drop the fluid, of course. And you're right, Dorothy, to question, can you see massive external hemorrhage? You can assume in that situation of those two injuries, it doesn't really matter because they're both going to be 90 millimeters anyway, our treatment point. But in that situation, if you could see an external femoral bleed, clearly you're going to be thinking that the stab wound is most likely, and if you're not, then you'll be thinking that the abdominal trauma is going to be the most likely. But well done, you've all gone for the correct answer. So final part of this little quiz here, you attend an RTC entrapment. A road traffic collision with a patient trapped. Shortly after extricating the driver, they develop a wide sinusoidal ECG rhythm. For those of you that don't know what that means, that is an ECG rhythm that's just really wide and no kind of coordinated activity. And they appear to become peri-arrest. So we've got an RTC entrapment. The driver's been extricated. They develop a wide sinusoidal ECG rhythm and they appear peri-arrest. What are we doing? Are we going to give them any fluid? Are we going to give them 250 a reassess? Are we going to give them a litre over the hour? Or are we going to give them 2 litres of rapid infusion? All vote now. Give it a go. So their ECG goes a bit funky and they start to look peri-arrest, and you get really worried about them after they've been extricated. What are we thinking here? Are we going to give them fluid? Are we going to give them your 250 bolus and reassess? Are we going to go a litre over the hour, or are we going to go 2 litres rapid? So split there. The correct answer is we'd have to think about crash syndrome in that situation. So the key there was RTC entrapment. They've been released and they deteriorate. The sinusoidal rhythm is not an uncommon finding in severe hyperkalemia just before the patient arrests. I possibly will do a session on hyperkalemia if that's something people want to talk about. I find it quite an interesting subject. So hyperkalemia and the treatment of may be a future subject. But yeah, the sinusoidal rhythm is quite is not uncommon as a peri-arrest rhythm. So if you're thinking crush syndrome, you treat for crush syndrome, which is 2 litres of normal saline rapid infusion would be most likely what that patient would end up getting. Until such point as they arrest, in which case the fluid will continue running and will just continue ALS. Wonderful. Well done. Let's head back to our non-hemorrhagic emergencies in that case. So, guideline basics are treat the underlying cause first. That makes sense, doesn't it? So, rapid infusion of fluid in medical emergencies, non-hemorrhagic emergencies, can actually be more detrimental. So, generally speaking, fluid is given more slowly in these situations. And I say we underlined as in pre-hospital care providers, don't treat dehydration. Treatment of dehydration is complex and it's based on electrolytes and blood chemistry that we don't have access to routinely. So we don't start a bag of fluid because somebody looks dehydrated. That can actually make them worse. So the main trigger, again, as with your trauma patients, was your impaired organ perfusion. We're looking for those patients that are shocked. A systolic blood pressure in a patient that normally has a normal blood pressure may indicate that. You may need to use a clinical judgment for those patients that are hypertensive, or you will for hypertensive patients. And don't forget, those patients with hypertension and other comorbidities are these patients that you're going to see in non-hemorrhagic poor perfusion. So they're going to start going into cardiac failure for whatever reason, whether that be an acute cardiac event or a combination or an exacerbation of ongoing heart failure, etc. So these patients are not necessarily the hypertensive patients are not the well patients, and they are the ones that you need to apply some clinical judgment to when giving fluids. We will talk about fluid overload and what to watch out for in a little while. With medical stuff, it's really straightforward. Generally, there are exceptions. There's always exceptions, but if you're undifferentiated, the blood pressure is lower than it should be, or lower than 90, and you're worried about organ perfusion, we're going to give 250 ml boluses. We're going to reassess in between each bolus, and we're going to give up to 2 liters. Nice and simple. The exceptions. There are exceptions. There are five in adults. Burns, sepsis, anaphylaxis, DKA, and adrenal crisis. I will go through each of them. I appreciate it is quite a long session, but this is where there's a lot more to just their blood pressures. They'll give them some fluids. Your Burns patients are dependent on size and distance from hospital. So size is always expressed in total body surface area. There are two numbers you need to remember, 15 and 25. If it's less than 15%, we don't need to give them fluids for that reason. They may need fluids for another reason. So for burns, they don't need fluid. If they're between 15 and 25% and you are more than half an hour from hospital, I'm going to suggest that patients with burns that high in pretty much every ambulance service I'm aware of, over 15% would pretty much guarantee you transport to the major trauma centre or a specialist burns unit. That patient is exceptionally lucky if the journey to hospital is less than 30 minutes. So generally speaking, we're going to be giving fluids to those patients. Over 25%, those patients are going to be critically unwell at some stage if they're not there and then with you. They are definitely indicated. So they're the numbers you need to remember: 15 and 25 for adults, slightly less for children, as you'll see. So less than 15, we don't need to give fluids for burns, but we might give fluids for another reason. 15 to 25 or over 25, depending on where you are, you're going to start fluids, and this is regardless of their perfusion status. In burns, you're preempting the fluid loss. So those patients I'm not suggesting that a patient with 25% total body surface area burns is going to be stable. They are probably going to be really, really unwell. But your 15 percenters can be stable. So you're going to give them fluids as a preemptive action for that fluid loss. You're going to do it slightly differently. It's 1 liter over an hour, and that's for everybody. We don't repeat that dose. The confusion will come if they're hypotensive for another reason, and you figure you need to give another bolus. But for just for burns, you're going to give the liter over the hour and reassess them. If they need further fluids for another indication, it's not saying that you can't do that. Sepsis. This is honestly fluid guidelines around sepsis. I've lost track how many times it's changed since I've been a paramedic. So current guidelines from JR Calc are 250 ml boluses over 10 to 15 minutes with a maximum of 1 liter. Don't know where that 1 liter comes from. JR Calc seem to be the only ones advocating the 1 liter maximum. I'm not sure where that comes from, but we're still 250 boluses. JR Calc still have this only if their blood pressure is less than 90. If you have a look at the Sepsis Trust guidelines, the Sepsis 6 guidelines for in hospital, you're 3 in, 3 out. Sodium chloride or Hartmann's is always indicated in those patients that are genuinely thought to be septic. Now, of course, genuine sepsis, those patients are compromised, they're cardiovascularly compromised, they're not necessarily going to have the best blood pressure in the world. And my teaching has always been, once you start to see a drop in blood pressure, they are indicated for fluids. I personally wouldn't wait in a healthy adult for 90 to start my fluids in sepsis. If I'm genuinely concerned by this patient and I think they're starting to decompensate, then I'm starting fluids. That is supported by the Sepsis Trust guidelines. JL Calc, I think, is a little bit behind the curve with their. They always have been in their sepsis guidelines. They're very hot on giving oxygen, which again, if you look at the Sepsis Trust guidelines, it's oxygen until you've got some confirmation that they're not hypoxic. But whereas actually we're the opposite with fluids. We're really prescriptive, and they need to be 90 millimeters of mercury and suspected sepsis for us to give fluids. I think we're a bit behind on that curve, but I'm putting it as a question mark. That's a guideline at the end of the day. If you don't agree with it, don't follow it. But you have to make sure that whatever you're following is evidence-based. If you're not going to follow JR Calc on that one, Sepsis Trust is a good place to look. Obviously, in hospital, they're very much more free and easy with the fluids, aren't they? So pretty much everybody with an infection gets a bag of fluids. So Anaphylaxis is the next one. So it's the problem in anaphylaxis, very similar to genuine sepsis, is that systemic extravasation of your circulating volume. You're depleting your circulating volume by leaking. It's a distributive shock as opposed to a true hypovolemic shock. It does develop rapidly in anaphylaxis. It can develop rapidly in sepsis as well. But thankfully, true anaphylaxis, and I think still count on one hand the number of true anaphylaxis I've dealt with in a 14-year career is still exceptionally rare. Severe allergic reactions, yeah, fine, but true anaphylaxis where we're actually at risk of distributive shock is really rare, thankfully. But the priority remains adrenaline. So fluids aren't your first thought in these patients. It's getting your IM adrenaline every 3 to 5 minutes for as long as it's indicated. If you do get to the point of giving fluids, and there are lots of other things we would consider for patients with anaphylaxis, it's a complex one to treat, but we're going to go rapid challenges of 500 ml to 1 litre, and we're going to repeat that as necessary up to a maximum of 2 to 3 litres. JR Calc says 2 litres, most in-hospital guidelines say 3 litres. Somewhere in that vicinity, we're going these patients can require huge quantities of fluid resuscitation, and then that comes into problems with some of the side effects of huge quantities of normal saline can actually be bad, but nowhere near as bad as genuine anaphylaxis, of course. So this is probably the most complicated one we're going to come on to. So make sure you're in the room. Diabetic ketoacidosis is a complicated subject, and it's one I've penciled for doing a session on altogether. I'm not going to cover what DKA is here. If you don't know what DKA is, it's a good one to understand because it tells you a lot about how the body works. If you understand how DKA works, you understand a huge amount about metabolism. So, we'll do a session on DKA at some point. It is really challenging to diagnose without blood, although blood and urine ketone testing is really common outside of hospital now. Loads of us have urine dipsticks and ketone strips for our glucometers that we can use. We're looking for anything over, so anything less than 0.6 is considered normal. Anything over 1.5 is abnormal. Anything over 3 is considered life-threatening. So our aims of treatment are to reduce the metabolic kind of car crash that's going on. Giving fluid alone isn't doing that. That's not definitive treatment. But we do give fluids because these patients become just with all the metabolic disturbance that's going on and all the electrolyte disturbance. These patients do lose their circulating volume quite considerably. Their cardiac output drops off, and their end organ perfusion is quite considerably affected, and quite quickly so too as well. The question you're going to ask yourself when treating this is adults at the moment is this patient shocked? So do they have signs of poor end organ perfusion? Do they have their blood pressure less than 90 if that's the target we're using? Do they look like they're in clinical shock? That's the question you ask. If no, but you still think they have DKA, it's nice and easy. It's a litre over an hour. If they are shocked and you think it's because of DKA, they're going to get 500 ml over 15 minutes and you're going to reassess. If they're still shocked, you're going to repeat that 500 ml over 15 minutes. So it's just two lots. In both cases, you're only going to give a litre. If that first bolus of 500 ml improves their circulating, their cardiac output, their circulating volume, and they don't appear shocked after that first bolus, it's possible, I suppose, in smaller patients. Then we're going to repeat that 500 ml still. All these patients get a litre of fluid, but we're going to do it over 45 minutes. So it's a slower infusion of that second dose. The evidence behind this links back to some studies that have found in DKA rapid infusions can cause cerebral edema. It's more in young patients, but they haven't discounted it as a possibility in all age ranges. So that's why we try and shy away from rapid infusions of fluid unless they are clinically shocked and they're losing their kind of perfusion status. So are they shocked? Yes. 500 ml over 15 minutes, reassess. Are they still shocked? Yes, do it again. If they're not shocked, do it again, but slower. If they're not shocked to begin with, just give them the litre over the hour and be done with it. Okay. In all cases, no more than a litre. In young adults with a low BMI, so they consider a young adult to be 18 to 25. I'm not one of those anymore. Then, and I don't have a low BMI either, so I don't, I don't fit into that one. It's a shame. But young adults with a low BMI, we refer to pediatric guidelines, and that's because they are more at risk of cerebral edema. Pediatric guidelines just does a weight-based dosing rather than, but the procedure is still the same. I'm going to ask the question: what about HHS? For those of you that have done any reading, say hyperglycemic hyperosmolar state, very similar in presentation to diabetic ketoacidosis. This is the one that affects more of the type 2 diabetics. DKA tends to be more exclusively the type 1 diabetics or the insulin dependent type 2s. The HHS hyperosmolar hyperglycemic state, as it says on the tin, everything except the ketones. So guidelines don't talk about HHS, but actually there is significant evidence out there that these patients should be treated exactly the same in that in the fluid aspect. And actually, to be fair, the treatment for DKA is insulin and dextrose infusion. Um, so ultimately, should we be giving fluid to a patient you think of HSS? I would say yes. The evidence would say yes, but our guidelines don't mention it. So it's just something to have a little think about. If you've never come across these terms, DKA and HHS, then definitely something to have a look at. Some good CPD. They are complex cases about how they manifest, but they do make these patients really unwell. HHS is no less serious just because they don't have ketones. So. Adrenal crisis, the last kind of little caveat to fluids. So it's rapid circulatory collapse because of failure to produce cortisol. So the priority of treatment still remains steroids, and in the mainstay pre-hospital is IV hydrocortisone. We do that first. That's the priority of care. And then if we get on to doing fluids, it's 1 litre over 30 minutes, and that's it. No repeat doses, no other bits and pieces. All these little caveats that I've mentioned, these six little nuances around fluids, these patients remain indicated even if necessarily their blood pressure isn't low. So these patients will get fluid. It's just in some cases the blood pressure or their perfusion status affects how quickly or how much. But these patients are all indicated for fluid. So your adrenal crisis, even if they are maintaining a blood pressure, they would still get their 1 litre over 30 minutes. It's more of a preemptive treatment. Hopefully that makes sense. So let's have a little quiz on those ones. Let me just get Menti back up. Next question then. We won't spend too long, just aware that time is running out. An adult patient with 12.5% burns is 45 minutes from hospital. Is fluid indicated? Yes or no? Adult patient, 12.5% burns, 45 minutes from hospital. Are we going to give this patient fluid? Yes or no? Please vote now. I'm going to hide responses again just because I thought I defaulted it to do that, but apparently not. Obviously, 9 of you logged in. It'd be nice if more than 2 of you voted. So 12.5% burns, 45 minutes from hospital. In an adult, are we going to give them fluid? Fab, that's half of you. So you've gone 50-50. Fabulous. Okay, lovely job. So the numbers to remember in adults, 15 to 25, less than 15%. They're not indicated for fluids, just for burns. So correct answer is no in that situation. Had that been a child, and we'll come on to children very shortly, they are 10% is the cutoff. If they're more than 30 minutes from hospital, we give them fluids. So in that case, no, we're not going to give fluids automatically. There may be other reasons why it would be indicated for fluids, but the burn wouldn't be it. A 30-year-old presents with DKA. Their blood pressure was 85 over 40 on arrival, and your colleague gave them 500 ml of normal saline over 15 minutes. Hopefully, you'll agree that was the right thing to do. They ask you to take over. The BP is now 110 over 62. What are you going to do? 30-year-old DKA, blood pressure initially was 85 on 40, and your colleague has given them 500 ml of normal saline over 15 minutes, which was correct. They ask you to take over, and the blood pressure is now 110 over 62. Are you going to withhold your fluids? Are you going to give them another 500 over 15? Are you give them 250 over 45? Or are we going to give them 500 over 45? All vote now. 30-year-old, not that the age really matters here, but DKA low blood pressure on arrival. We've had the correct treatment so far. You've been asked to take over. What are you doing next? Blood pressure is now 110/62. Another 500 over 15, 250 over 45, 500 over 45, or you're not going to do any more fluid. Let's see where we're all going. Oh, nice split. I like it. And nobody's gone for the correct answer. So let's break that one down a little bit. So DKA, are they shocked? On arrival, yes, they were. The correct treatment was 500 ml over 15 minutes. Reassess, are they still shocked? Blood pressure 110 over 62. For a 30-year-old that's normally fit and well, probably isn't shocked. So you change your track slightly. You still give them the other 500 ml, but you do it over 45 minutes. Hopefully that makes sense. The only time you would give the 33% of you that have gone for 500 ml over 15 minutes, you would only do that if they were still shocked at that reassessment. So the blood pressure was still below 90 or there were clinical signs of shock. Hopefully that makes sense. Okay, and the last little bit for that one. An 18-year-old presents in adrenal crisis. What is the correct initial treatment? Are you going to give a litre over 30, a litre over an hour, 250 and reassess? Are you going to give hydrocortisone? What are you going to do first? Patient in adrenal crisis. What's your correct initial treatment? There's 10 of you logged in now, which is great. Let's see, at least half of you have a go at this. Let one more of you have a go and we'll see where you're all going. Lovely, perfect. 250 and reassess and IV hydrocortisone. Don't forget what I said. Your priority of treatment in adrenal crisis remains steroids. Okay, I know it's a lecture about fluids, designed to catch you out, which it caught half of you out. So the other half, just have another little look at that page. So it's 1 litre over 30 minutes for adrenal crisis, rather than the standard 250 and reassess. So an 80-year-old in adrenal crisis, the first thing you should be doing is 100 milligrams of IV hydrocortisone. Wonderful. Let's go back to this one, and we're going to talk about kids. Yay, children. So basics, and I remember teaching similar things around oxygen. The child that lets you give them fluid needs fluid. It's nice and simple, isn't it? So there are challenges, aren't there? Giving fluid to children is a problem. IV access is not easy to get in a distressed child. Diagnosing shock can be more difficult, and of course, dosage of fluid becomes weight dependent as opposed to just a standard number you can remember. There are two sets. Medical cause, so we've gone from hemorrhagic and non-hemorrhagic in adults to children, we go medical versus trauma. Similar, but not quite the same. So medical cause standard is 10 ml per kilo, except if they have heart or renal failure, then we half that dose at 5 ml per kilo. These are initial doses. You stop if there's any deterioration. That's just again the likelihood of causing cerebral edema. Traumatic causes, we limit to 5 ml per kilo for initial doses, except burns where we increase it to 10. Clear as mud? Hopefully. Perfect. In all cases, the maximum total dose you can give a child without some kind of pediatric involvement is 20 ml per kilo of normal fluids. So medical cause basically 10 ml per kilo. Traumatic cause is basically 5 ml per kilo. The exceptions you need to remember in medical, if they're a child with heart or renal failure, we half the dose. And in trauma, if it's burns, we double the dose. So we go back to 10 again. Lovely, isn't it? So DKA, the little caveats with kids, they are basically more simple, even though that slide doesn't necessarily make it sound that way. But DKA, we're most worried about cerebral edema. And as I say, there are studies that link rapid fluid replacement in young people with DKA as developing cerebral edema. Basically, do what you need to do, but stop if there's any deterioration in GCS or you see any acute neurological signs. So signs of cerebral irritation, seizures, those types of things. The Burns guidelines, exactly the same, except the numbers change. So it's 10 to 20. We've got a slightly lower threshold with a child, which makes sense. So burns less than 10, we don't give fluids for burns. 10 to 20, we only, if we're more than 30 minutes. A child with a burn of 10% is going to a trauma centre / burns unit. Again, they're very lucky if they happen to live within 30 minutes of one of those. and over 20%, we're always going to give fluids, but those patients are not going to be well. They're going to require lots and lots of other care going on, but that is the indication for fluids. Remember, for burns, it's not your standard trauma dose, it's your 10 ml per kilo. And as with adults, we're giving our burns doses over an hour. Okay. There is one more quiz just on kids, and then the rest is just me talking about a few other little bits and pieces. So appreciate we have gone over slightly on time. I think I always used to do that, so nothing's changed. A 7-year-old with a history of a birth defect with his heart. That's all you get told. That's what the parents tell you on arrival. He's got a birth defect with his heart. Presents in decompensated cardiac failure and his ketones are 3.6, so you know what you're dealing with here. But what is the maximum fluid volume that you can administer to this child? 7-year-old with a history of birth defect in his heart. He's got decompensated cardiac failure. We're assuming that's because of DKA, aren't we, with the ketones of 3.6. What is the maximum fluid volume you can give to that child? 10 of you, let's let at least half of you have a go. And this doesn't let you put an extra line on Mentimeter unless you pay for the really expensive one. But that should say the caveat should say without pediatric guidance. So, what's the maximum dose that you can give? Let one more of you have a go, and at least half of you have a go before we put the answers up. No. Okay, so 5 ml per kilo or 20 ml per kilo. Oh, we've had all options, but I'm glad nobody's gone for no fluids indicated. This child definitely needs fluids. Correct answer: total dose. The maximum fluid volume you can administer to any child, regardless of their past medical history, is 20 ml per kilo. The only difference is you'd be giving it in 5 ml per kilo doses. Okay, so in theory, you'd be giving 4 doses. Or you could give 4 doses for GKA in a child with a history of congenital heart. You don't know whether that birth defect causes heart failure or not at this stage, so you just have to assume it might do. You'd limit your individual doses to 5 ml per kilo, but you can still go to 20 ml per kilo. I wouldn't go beyond that without speaking to peds. But there we go. Well done for the one that got that. Always trying to catch people out, of course. But you learn more when you get it wrong. That's what I've always said. So. I'm going to whiz through these bits. I appreciate we are going to run over time. There's a little bit more information coming up, but as I say, this will go up to YouTube, and you can have a little look at it later. So there are some limitations of fluid resuscitation. There isn't a huge amount of evidence that it works, and actually there is some growing evidence that in certain situations it makes things worse. It can be time consuming, and the overarching principle of all these things is these patients need to be in front of clinicians in hospital that can fix them, not just fill them full of water. So sometimes the act of getting IV access and hanging your fluids can be time consuming. So just bear that in mind and how that rubs off on your on-scene times and time to definitive care. This is the problem with normal saline, and we're going to talk about options that aren't normal saline. But the problem with normal saline is it has quite a high chloride content. It is sodium chloride. And that excess chloride will eventually cause hyperchloremic acidosis. It's one of your non-anion gap metabolic acidoses. And that is problematic. It can cause problems with the kidneys, predominantly. And there's lots of evidence coming out now that actually sodium chloride might not be the benign substance that we've all thought it is all these years and just been giving routinely to patients. And in fact, the evidence now suggests that it's detrimental to routinely administer fluids only to those that need it. So the three things that they always go on about, don't they? When you do any kind of trauma training and we look at fluids versus blood, whole blood or other substitutes, fluid is cold usually. So think about your trauma triad of death. Your hypothermia causing acidosis, which causes reduced cardiac output, which exacerbates the hypothermia, which exacerbates the acidosis, which exacerbates the reduction in cardiac output. So that's your trauma triad of death you're playing with there. If you're thinking midwinter, I mean, at the moment, I reckon you wouldn't need a fluid warmer at the moment. It's certainly in this house. You could have lovely room, lovely body temperature fluid going in. Fluid doesn't clot. It's got no clotting abilities, and it doesn't carry gases, does it? It doesn't help at all with your carbon monoxide or oxygen exchange. And you've got to think about what we're actually trying to achieve with fluid resuscitation. And actually, all that sodium chloride does, it acts on two mechanisms. So, if you want some really interesting bedtime reading, if this hasn't been enough for you tonight, then have a look at the Bainbridge reflex. Bainbridge reflex is the reflex that occurs when the baroreceptors in the right atrium are stimulated. They get stimulated by increasing preload. So, if you've got more volume or pressure of blood arriving in the right atrium, and think back to where we put our fluid, we put cannulas usually in the ACF if we're looking for large bore, and we drop our fluid direct in there. That drains it to subclavians and into the superior vena cava, into the right atrium, doesn't it? So we're going to stimulate those baroreceptors and cause the Bainbridge reflex, which is to increase heart rate to try and clear that excessive preload, excessive relative term. But so we increase our heart rate in response to baroreceptor stimulation in the right atrium. The Frank-Starling mechanism, Frank-Starling law of the heart, says that if you increase, again, if you increase preload, you increase ejection. So if you stretch the heart on filling, when it actually actively compresses, actively beats and ejects that blood, whether it be into pulmonary or systemic circulation, you're going to have much better cardiac output. So they're the two laws that we're playing on here. So again, if you preload the heart, you get better output. It's common sense, but there are physical laws, physics laws behind these. Fluid overload is a risk, and this is why we've gone away from practice of everybody gets a bag of fluid, or we do keep vein open and that type of practice. This is why it's frowned upon. And fluid overload is a great term, hypovolemia. It's caused because actually, so sodium chloride, normal saline, it's also known as, is because of the molecular buildup of the fluid, it can leave extravasate is the posh way of saying it can leave the blood vessels, and up to two-thirds of whatever you pump into somebody's vein actually ends up in their tissues. It actually extravasates, and that is going to lead to edema in eventually, isn't it? And that fluid overload that we typically associate with patients with heart failure, where you see their edematous legs, you hear pulmonary edema in some situations. That risk is obviously increased in those with cardiac disease, whether that be heart or vessel related. Those with renal failure, they can't clear that excess fluid. Obviously, that's a bit of a slower process. In children, there's definitely evidence that rapid fluid replacement and extravasation, particularly in intracranial spaces, can cause that cerebral edema. And the risk is obviously increased in rapid infusions. So we are talking about guidelines suggesting rapid infusions in certain situations, they're balancing the risk of that extravasation causing flash edemas and things like that. In those at risk, then we do advise giving cautiously slower or smaller infusions where that's appropriate, and assessing lung fields of sinopulmonary edema. I think that's generally the first place that you're going to pick up. But again, it does depend on where their underlying disease is. If they've got left ventricular outflow obstructions, then of course you're going to see pulmonary edemas developing quickly. Remembering that with the heart, it's where you see the symptoms are backwards. So if you've got a left ventricular outflow issue, you're going to see backup in your pulmonary circulation where that enters into the left atrium. Where you've got some kind of right ventricular outflow issue, you're going to see systemic edema. That's where you're going to see the pitting in the legs, the sacral edema, those types of things. So just with the heart, look back, and that's where you'll find the symptoms generally. So in truth, though, if you've got major heart failure, you're going to see both, aren't you? So are there any better options? Crystalloids and colloids are often talked about. So what are crystalloids? So crystalloids include normal saline, 0.9%. So normal saline is often abbreviated to NS. So that's what you're seeing there. Crystalloids, normal saline, and Hartmann's, which we're going to talk about in a minute. They're considered crystalloids. Crystalloids are smaller molecules. They can extravasate, that we talked about, and cause edema, but they are considered to be isotonic in that they more closely resemble the kind of baseline hemodynamic biochemistry. There is evidence of harm in larger quantities, mostly renal damage, and that's more associated with normal saline, as we talked about with the hyperchloremic acidosis that can result. Colloids, on the other hand, are things like albumin, dextran, gelifusing. I would say albumin and gelifusing probably is the most. They're larger molecules. Those molecules can't extravasate. They can't leave the vessels, and that way they remain in circulating volume with greater osmotic actions. So they cause a bigger osmotic gradient. Might have to just kind of Google osmosis and remind yourself over the kind of concentration gradients and how fluid will move from one compartment to another as long as it can, in order to try and balance an osmotic gradient. So they do last longer, and you don't require as much. Um, Adverse reactions, they are more synthetic in kind of nature, and adverse reactions are much more common to colloids versus crystalloids. They're not all vegetarian. Some of them contain gelatin, which may be a factor in some patients, probably not so much in the emergency setting. But on top of that, they're much more expensive, and unfortunately, that's where the line is drawn, isn't it? In most cases in pre-hospital care. So both are supported by NICE. There is no very strict guideline on you must use this in this situation, use that in the other situation. Albumin is very effective in all indications that you would consider normal saline or Hartmann's for. Crystalloids are generally favoured in initial resuscitation. I think that's just familiarity, cost, availability, and a lack of evidence in any other direction, to be honest, is why crystalloids are favoured in initial resuscitation. In hospital, you're much more likely to have your clinicians, if you're on fluids long term or for more complex reasons, there's much more likely to be a discussion around crystalloids versus colloids for you. They are usually the only option outside of hospital. I'm not even aware of our HEMS teams having colloids available to them, although I'm sure somebody will message to say it exists somewhere. So realistically, our decision is between sodium chloride and Hartmann's. And again, NICE and JR Calc both support both sodium chloride and Hartmann's. Traditionally, Hartmann's has been more expensive, but now actually it's cheaper. For my current supplier, Hartmann's is a few pennies less per 500 ml than sodium chloride. They're both supported for the same indications-ish. They're both readily available. They're both something that paramedics can order. They're both Schedule 17 Part 3 medications. There's no legal reason why a paramedic can't choose Hartmann's over sodium chloride. They're both readily available. They're both similar cost, and both very well used in hospital. Pre-hospitally, we seem to be stuck with just sodium chloride, and there doesn't seem to be any real reason why, other than just that's what we've already done and it used to be cheaper. So let's have a little look at what the difference is. So Hartmann's correct term is sodium lactate compound. Over here in the UK, it's known as Hartmann's. It will say Hartmann's on the bag most of the time. In the US, they tend to call it lactated ringers or ringers lactate. It's pretty much the same stuff. There's some very slight differences in the constituents. Sodium chloride, normal saline at 0.9% is considered an isotonic crystalloid, whereas sodium lactate or Hartmann's is considered a balanced crystalloid. You'll hear those terms. So balanced just means it closer resembles the body's kind of homeostasis than sodium chloride does. If we have a little look at what's in them, so sodium chloride, no, not surprised, has sodium and chloride in it. It has about 154 millimoles of each. There's a pH 4.5, which I remember years ago when I first got shown a slide like this, and I thought, really? It's that acidotic. So it is, sodium chloride is acidotic. That's where this hyperchloremic acidemia comes from. So sodium lactate compound, let's have a little look. There's a lot more in it. So we've still got sodium and chloride in lower volumes. And if you look down at the bottom, normal biochemistry markers there, you've got a normal serum sodium of 135 to 145. So your sodium chloride has 154, a lot more, well, not a lot more, a little bit more. Whereas your Hartmann's is within that range. Your chloride, again, your Hartmann's is just over. Your Hartmann's also contains potassium at a kind of normal biochemistry level. We have some calcium in there, not quite as much as in the free flowing. We have some lactate in there, but lactate, as you'll see shortly, it metabolizes into bicarb. So it's at around the same level, slightly higher than the bicarbonate that's floating around the body anyway. So that actually has a slight buffer effect, which is quite nice. You can see there that the pH is still 6 there. It's still acidotic. It's acidic, sorry, not acidotic. It's still acidic, but not as bad as sodium chloride is. Obviously, normal pH are 7.35 to 7.45. So let's do some myth busting then, because everybody seems to come back to two things. Everyone I talk to about Hartmann says, yes, you can't use Hartmann's in sepsis. And I always go, why? And they usually go something like, because it's got lactate in it. Get it? So, it's fake news though, isn't it? So, let's have a look. Lactate does not automatically become lactic acid, is the key thing you need to understand here. Lactate undergoes gluconeogenesis and oxidation when it passes through the liver. So, the gluconeogenesis pathway produces pyruvate, and that's metabolized further into acetyl-CoA and then enters the Krebs cycle. Oxidation results in release of bicarb and CO2. So don't forget there will be some when we look at acid-base balance, the resultant CO2 from this process will affect it somewhat, but predominantly it breaks down into bicarb, and bicarb being a buffer. It's an alkalizing agent. And don't forget, obviously, there will be CO2 from the aerobic respiration process of the Krebs cycle as well. So there is overall there is going to be some increase in CO2 in the blood, but actually much more prevalent is going to be an increase in bicarb, and that's why we measure the lactate in Hartmann's solution against the bicarb level in the blood rather than a normal lactate, which obviously would be less than 2. So it doesn't actually become lactic acid automatically. So that lactate metabolism results overall in a pH buffering. So actually, when we're looking at sepsis, and we're worried about high lactate in patients with sepsis, anything over 2 is considered significant. I can understand where that thought process comes from, but actually we can disprove that. So actually overall there is a pH buffering effect of giving sodium lactate compound or a Hartmann solution over normal saline. But actually studies have not shown any outcome difference. So the main issue we're trying to get away from is this hyperchloremic acidosis, which is actually more significant than the overall pH buffering effect that you're going to get from giving Hartmann's solution, if that makes sense. So, food for thought. I'm not saying this is why I'm saying myth busting question mark. I'm not going to stand out there and say everybody should be getting Hartmann's solution for sepsis, but it's something to think about because lots of people say you can't give it because of the lactate. It's not true. So, next myth. You can't use Hartmann's in DKA. Why? Because JL Count used to say in it. So JL Count did used to have a section on sodium lactate compound in their drugs section. It's disappeared, and they just mention it in their fluid guidelines now as being a suitable alternative to sodium chloride. But it used to be contraindicated in DKA. It's still a contentious issue, not going to lie. I've looked at lots of papers around this. The hesitation still seems to come from this lactate being there and worsening the acidemia. There are 2 studies that I've picked up on recently, probably the most contemporary ones that I can find, bearing in mind full disclosure, I haven't done a full literary search here, but the Self et al. In 2020 looked at 172 adults, and Young et al. Looked at 77 children, both with DKA, and they directly compared normal saline versus DKA over hospital admission times and general recoveries, and both found a benefit in severe DKA. Now, both authors reported statistical significance, but ultimately they are small cohort studies, so they are whether they are enough to change practice. Clearly not, because current guidelines still recommend normal saline, but they do acknowledge that risk of NAGMA, the non-anion gap metabolic acidoses. But crucially, they don't contraindicate Hartmann's anymore, so we are chipping away at that, and there may be evidence that in severe DKA, Hartmann's is going to be the better of the 2 to give. So they're the two little myths that come up. So, and the last little session really is just talking about head injuries when it comes to fluids. So there are studies that support normal saline over Hartmann's. So there are times when Hartmann's may not be your first choice. And this all comes down to the mechanism of what's going on in traumatic brain injury. I appreciate, guys, this has gone on a lot longer than I was thinking it would, but the first in the series always does if you look back. So, in traumatic brain injury, the swelling, the rise in intracranial pressure in TBI is multifactorial. It's not just the swelling, the edema that builds up on the brain. There's lots of other factors, bleeding being quite a significant other one as well. But the swelling and edema of the brain is one of the causes of raised ICP. And don't forget, edema is just extravasated fluid, isn't it? It's fluid that's not where it's supposed to be. It's left the blood vessels. So, the reason why we start to think about sodium chloride and hypertonic saline is to do with this cerebral perfusion pressure. That really is the key. So cerebral perfusion pressure is the difference between your mean arterial pressure that we talked about earlier, so your diastolic plus a third of your pulse pressure, minus your intracranial pressure. Now, clearly, in the pre-hospital setting, we can't measure ICP. I'm not going to suggest you get your Black and Decker out and start having a little feel. But in the context of suspected traumatic brain injury, if you're seeing a rising mean arterial pressure, you can assume it's because the ICP is rising too. The body that is a protective measure. It increases its mean arterial pressure through various mechanisms to overcome that rise in intracranial pressure to preserve the cerebral perfusion pressure. So you have to get the blood up into the skull for it to perfuse the brain. If the pressure in the skull is increasing, then the pressure of the blood going into the skull has to increase. It does make sense, although the words are quite long. But once it gets to the point where it can no longer overcome, we're going to get significant secondary brain injury. The brain effectively is going to start getting starved of blood and therefore oxygen and glucose. This is why the threshold is higher for head injuries, and I mentioned that we'd come back to this. This is why that guideline says 110 millimeters mercury for your head injury patients. It is exceptionally unusual. I can't give you a scenario off the top of my head of one I've seen where the head injury itself is the reason the patient is hypotensive. They're usually hypotensive for another reason. But if they are becoming hypotensive, that is a critical situation. What if, as we said before, if you don't have that systolic blood pressure to begin with, there is no way that you can overcome a rising intracranial pressure and preserve cerebral perfusion pressure. Ergo, you are going to cause secondary traumatic brain injury. And as we said, that cerebral edema is just extravascular fluid. It's fluid that, for whatever reason, has left the circulating volume and accumulated in the brain. So if we introduce an osmotic gradient, start thinking back to your GCSE science here for a minute. If we start putting an osmotic gradient in the intravascular space, we'll reduce that edema, will we not? So normal saline has 150 millimoles of of sodium ions, and that is mildly osmotic. We know that normal circulating volume and okay, the osmotic gradient of the or the osmotic pressure, sorry, of the edema that has collected in the brain is going to be around 135 to 145. So if we start increasing the levels of circulating sodium beyond that, we're going to start drawing fluid from the extravascular space back into the intravascular space. There are limitations. We know that sodium chloride can extravasate, and that process isn't going to last long. But it's preferential to other agents, it would seem, in the evidence anyway, which we'll come on to. So hypertonic saline is talked about. So you think, well, normal saline doesn't quite have that osmotic gradient that we need to make any real difference. So we start to look at hypertonic saline. There's two main concentrations in use pre-hospital. 2.7 is by far the most common, 2.7% saline. So there's 462 millimoles of sodium anion cation, sorry, in the 2.7 saline. And 5% saline, you may also see, I know CCAM critical care practitioners carry 5%, which contains 855 millimoles, so significantly higher. That is going to create a much bigger osmotic gradient than normal saline, and the theory and the evidence seems to suggest to support that is that you're going to drag that fluid effectively back into the intravascular space of the brain, reducing the edema. Key here is we're reducing intracranial pressure and therefore allowing better cerebral perfusion pressure for any given mean arterial pressure. As we say, 2.7 is the most common. It's also available in 3 and 5%. 5% is growing in popularity because of a recent study There doesn't seem to be an ideal concentration at the moment. This is still quite a new and upcoming area of pre-hospital medicine. But a recent study has suggested that 5% had improved outcomes versus 2.7. There's another agent, another colloid agent called mannitol that's often talked about in the case of traumatic brain injury. It's very widely recognised as being a good treatment, but there's been a recent systematic review. Those of you that follow the resuscitation a couple of months ago, they did a Papers of the Month, and this paper was covered. It's a systematic review article that has shown significant benefits, and it's worth listening to that episode because there are some study limitations that do make this less statistically significant, but the significant benefits over mannitol. But as they also picked up on, nobody's really compared this to placebo. So but we're probably past that point of doing studies on placebo now because we have seen positive outcomes from giving these patients hypertonic saline or mannitol. In settings where hypertonic saline is available, it's indicated for traumatic brain injury with clinical evidence of significantly raised intracranial pressure. So you're thinking about your Cushing's triad there with your hypertension, your bradycardia, and your altered breathing, which are very late stages and indicative of brain herniation. Again, you're going to be looking for your deterioration in GCS throughout that process. Dose at the moment seems to be fairly standard across the board at 3 ml per kilo via slow infusion over 10 to 15 to 20 minutes, depending on your local guidelines. Currently, that's for all strengths, so it was the same guidelines in the 2.7 as I could find in all the 5% guidelines. So 3 ml per kilo. There is a safety alert here, though. You can potentially give the patient enough sodium to put them into cardiac arrest. So we need to make sure we're getting the dose correct and never connect your bag of hypertonic saline to a cannula, even if it is through a three-way tap. It's a pain, given a 100-kilo adult is going to get 300 ml, so you're going to have to fill 6 50 ml syringes. But that's what you do. You don't connect a three-way. You don't connect a giving set and a three-way tap. You just draw it up and administer it. So we've got to mention cold versus warm, and my question back would just be, well, why wouldn't you? So cold fluid versus warm fluid, you just have to do a Google search and look at how many papers come up. But the one that I flagged there is Wall 2018, and they found that actually that increasing the temperature had a greater effect on the mean arterial pressure than increasing the volume of the fluid did. So just think about that, how important warm fluids are. So why aren't we doing it? Clearly, it's better tolerated, it's less shivering, etc. We know from the trauma triad of death that giving warm fluid is not going to make the coagulopathy any worse than diluting would. But the limitations seem to creep in then. So when did you last see a fluid warmer in an ambulance? I can't remember the last time I saw a fluid warmer in an ambulance. I know some trusts used to have them. I'm not aware of any. Well, certainly the two that I've worked with in the recent years don't have fluid warmers. We don't have access to warm fluid. It's a shame, really, because actually it's not that difficult to achieve. The other question that there isn't a definitive answer to, though, is actually from a medicines management point of view, is can you store your fluid, whether it be normal saline or Hartmann's, at 38 degrees until the expiry date, or do you need to reduce the expiry date? I couldn't actually find a definitive answer on that. And those of us that work in the setting I currently do of being out at events and things like that, you've got to think about how you're actually going to keep your fluids warm. There is a power supply issue there, but mobile fluid warmers do exist. I have one. They are out there. So I do think we probably need to reevaluate why we're not giving warm fluids more often. I don't think this is something that's not achievable in an ambulance service. So. To complete the session, we've got to talk about glucose. It's not a resuscitative fluid, but it's worth just mentioning here in the fluid guidelines section. It's available in 5 and 10% solutions is the most common. There are other solutions for specialist tasks out there. Pre-hospitally, we use 10% more often than not. It's typically only used by us pre-hospitally for hypoglycemia, but it is also indicated by the EPALS guidelines in prolonged pediatric arrest. 5%, that's the other most common, probably more common solution out there. It does have lots of uses. We mix it with normal saline for maintenance fluid for patients that are in hospital for long periods of time in ICU and those types of things. Mixed with insulin for DKA and hyperkalemia. Again, probably both subjects that I'll talk about in more depth later. And again, in pediatric advanced life support, in certain situations, you would mix 5% saline, 5% glucose with sodium bicarb. Adult dosing is fairly straightforward. It's 10 grams, which is 100 ml of 10% dextrose or glucose, given every 5 minutes or until the blood sugars rise. We tend not to give more than 30 grams or 300 mils without discussing with a senior clinician, just because we need to start thinking about why it's not coming up. With children, more straightforward. It's just 2 mil per kilo of 10%, so 200 milligrams per kilo of actual glucose being administered. And again, you would just repeat that dose as necessary until the blood sugars were normal. But again, if you weren't seeing a rise after a couple of doses, we need to question why that blood sugar isn't coming up. It's been a long session, but we've got to the end. So thank you for bearing with those of you that are still clinging on in there. We're going 2 weekly at the moment, as I said. The next session I intend to do is on pre-hospital bloods. Moving to Tuesday, we were looking for a day that worked reliably, and it turns out Monday wasn't that day. So we're going for Tuesday. So Tuesday, the 26th of August, and then the plan will be every other Tuesday and see how we get on with that. And I'm moving it slightly later as well to 7:30. We'll be 26th of August at 7:30, pre-hospital bloods. Have a look on our website and Facebook in the next day or two, and there'll be a registration link available. I do intend to give out CPD certificates again. To date, I haven't been able to find a cost-effective solution that allows me to automate the process. Unfortunately, I just don't have the time to do handwritten certificates for everybody that attends and everybody that then watches on YouTube. If anyone can recommend somewhere that I can do an automated certificate that isn't going to cost a fortune, because I don't charge for these webinars, then please do let me know. But I'm still looking for somewhere. But there will be something in place to get you guys a certificate in the future. So I'll take questions. The chat is open. It's all yours. If you don't want to ask in the chat, you can email me or text me. As I say, I'm never going to charge for doing this. I enjoy it as part of my own CPD. But if I have helped you and you'd like to buy me a coffee, then there is a website called Buy Me a Coffee. Who knew? Innes Eaton is the username there. Most appreciated. There is a cost to producing these. I have to pay for a license to Zoom and to Mentimeter. So these aren't free to produce, but as I say, I do enjoy doing it, and I don't ever intend to charge for them. So gifts are always welcome. So I'll take any questions. I know it's been a fairly mammoth opening session, like an hour and a half, but and who thought fluids could be so interesting, eh? But if there are any questions, and again, I appreciate that most people that are watching this are going to be doing it on YouTube. So any questions, I'm always happy to answer via email or WhatsApp. And otherwise, we look forward to the next session. Try and get a bigger audience. We'll try and circulate things around. It's always helpful if you guys can circulate around your networks as well. Every one person that you bring in doubles the numbers. So, but great to see the familiar faces back. And as I say, other than my little flashbacks to COVID lockdown, it's been quite an enjoyable process putting this together again. So.